Well, welcome again. This is the last installment of the Public Economics of Health Policy in Developing Countries. Just to recap where we are in this presentation, as I've repeated several times, the point of much of this presentation was really just to compare the three broad categories of intervention on three major dimensions of relevant considerations for good policy, and we were just about finishing up the discussion of primary health care. I am claiming that there are modest efficiency effects for primary health care, potentially high equity effects, but something of an empirical question. And I am also contending that the management problems of primary health care are extremely hard. So first on the efficiency effect, just one slide that was relevant. I'm contending, at least with the use of Indian data, that identifying the market failure in the private sector isn't all that easy. I mean, we have lots of preconceived notions of how the markets screw up all the time. We have the argument about asymmetric information, about how doctors can talk patients into things they don't need, and this is one of the reasons why there might be a market failure in primary health care. But in looking at India and Indian data, this just doesn't jump right out at you. It's not really obvious that this is a big problem. I did give you a short story about we're not sure whether doctors talk patients into things they don't need, as opposed to patients talking doctors into doing things like giving intravenous glucose drips, where it wasn't really the doctor's initiative at all. It was the patient's initiative. In the research that was trying to compare what do doctors know as opposed to what do doctors do, in the private sector, we had some real mysteries going on because the private doctors aren't doing a whole lot more than the public doctors, even though they're paid to do it. So they're not, it's really hard to see them doing too much relative to checklists and standard procedures. The private doctors are doing too little. The public doctors are doing way too little, but the private doctors seem to be doing too little as well. So that's a tough one. And on the very specific point of doctors know something that the patient doesn't know and decide to do more than that, when we look at the data, we have only a small fraction of private doctors, 17% or so, that we know because of these hypothetical cases that they shouldn't do too much, but then they do it anyway. 17% is a problem, but it's not exactly an overwhelming one, and therefore I'm contending that the market failure just isn't that stark and dramatic. Yes?
Hi, so 17% of what? So my question is, what's the sample size that you have taken?
Oh, the sample.
Private and public.
Yes. These were the samples in Madhya Pradesh for the interactions between doctors and patients. There are about 400 MBBS doctors and about 400 less than MBBS doctors. The split between public and private among the MBBS doctors, I'd have to look up.
See, I suppose it's scope for more research, but maybe their behavior varies when you're talking about high-cost treatments like surgeries.
We're talking about primary health care. We're about to go into high-cost treatments. In fact, that's more or less the point. It's for primary health care, these things are not particularly expensive. It's unclear how much money doctors could extract out of poor people out of pocket anyway. This will become a big problem when we start talking about hospitals. Okay. So on the first dimension, efficiency, yeah, there could well be an efficiency problem with private medical care. The quality of care throughout the country, public, private, everything, is pretty low. But it's unclear that it's a market failure or a particular failure of the private sector. It's just a really bad situation across the board. Not necessarily fixed by expanding the public sector because the difference isn't necessarily that big. So efficiency, doubtful, unclear, needs more research. On the equity effects, frankly, there hasn't been relevant national data or even statewide data for most states for approximately 20 years now. So it's entirely an empirical question as to who goes to the primary healthcare centers. Is it mostly poor people? Is it mostly rich people? Things could very well have changed in the last 20 years. There is just not the data to say. What I would like to caution people about is this is an argument that's frequently put forward, but it's entirely an empirical argument on which we have no empirical evidence. On international grounds, the evidence is basically the other way around. That is, medical care seems to have a high income elasticity, but we don't know about that for India. So on efficiency effects, unclear. Equity effects, also unclear or at least unknown, but it is a researchable topic.
So this is for primary
care.
Do we know for public hospitals?
Hospitals are coming in a second. And then I made a big deal about the management problems of primary health care in public sector, that there seems to be all kinds of difficulties in managing this dispersed network of doctors. Doctors are very individualistic type people. Many people talk about managing doctors as in herding cats. And of course, the doctors are themselves very reluctant to listen to non-doctors who are managing them. So even secretaries of health, doctors go, well, he's not a doctor, so and therefore kind of difficult to manage. And we see vacancies, we see absenteeism, we see questions about capabilities, and we see very little effort. There was one slide that did not come out yesterday that I really did want to talk about, and this was that it is not an issue of public versus private about whether or not poor people get good care or not. It really is poor versus rich. And this was the diagram I wanted to show. And the eminent Indian economist that I was referring to likes to say that the private sector has a lot of quackery and crookery. I'm saying all poor people face doctors who are doing that. On this diagram, the x-axis is the standardized scores. Everything is a mean of 0, standard deviation 1. You can see that these must be very skewed kinds of variables. And in this diagram, the blue dots represent the competence, and those are those measures of how much doctors know in their hypothetical interviews. And the red triangles are how much effort, how much time, questions, and procedures do they normally give. And I would say that a good measure of competence would be whether or not you reach the mean of the sample of doctors. And so those would be blue dots off to the left of the of 0. The two lowest ones are both in poor neighborhoods. In poor neighborhoods, private doctors aren't particularly good. That's the very top blue dot, private doctor in a poor neighborhood. But curiously, in poor neighborhoods, the private doctors, who are many times not well trained, seem to score better than the ones in primary health care centers. This is quite a disturbing finding. And private doctors in middle class, middle income, not middle class, aren't so hot either. But the two outliers, or the two lowest, are in fact the low capability of doctors in poor neighborhoods. Then when we turn, and I would say that if we were going to define quackery, it would be people who don't know what they're doing, right? And those seem to be in poor neighborhoods, public, private, not much of a difference, it's poorness. Crookery, well now crookery in the private sector you could define reasonably easily. It's whether or not they're taking a whole bunch of money that it's not worth. That's clear. However, I could also suggest that if you're paid a salary, most people expect you to do your job. And if you're not doing your job conscientiously, that's kind of another kind of crookery. I think that's reasonably a plausible story. So let's look at the effort put into primary care interactions. And as you see, all three of the red triangles, which represent effort, that combination of the three, all three of the ones that stick out over there on the left are PHCs in poor neighborhoods, middle neighborhoods, and relatively well-off neighborhoods. And the effort of a public doctor in a poor neighborhood PHC is almost 2 standard deviations less than the sample mean. I would say that that's a reasonably good definition of crookery. So in poor neighborhoods, very low competence, quackery, very low effort, crookery, no matter where poor people go. Okay. And then, just to summarize, I propose that the big problems in public provision are all based on incentives, and the basic incentive structure that's a problem here is you're paid by a salary, you're not monitored by supervisors, you will not be fired or have your pay reduced under virtually any circumstances, you're of a much higher social status. These are doctors in rural areas and have much greater political power than your clients. Complaints can't possibly reach you, and you have lucrative alternative work in the private sector. This sets up an enormous incentive problem, and it really leads us to ask, what would you do if you were in this circumstance? And I think it is not surprising that we get so little effort out of public doctors. Now, I'm paid by a salary. I'm not sure how far I want to go into this. I'm paid by a salary, and actually I'm not carefully monitored by supervisors. In fact, I don't think the deans ever entered my classrooms. However, I am kind of monitored by my students, and while they might be perfectly happy to have 1 or 2 classes skipped during the semester, they probably would not like it if I was absent 40% of the time, and the deans would certainly hear about that. Whether they could fire me or not that semester, unclear, but it would be very uncomfortable for me. So yes, I am kind of monitored. Tenured faculty can't be fired, but if there's inflation, they can have their pay capped and never see an increase. So actually they are kind of rewarded for better, or they can be punished for bad service. The last one is, I may be approximately the same as my graduate students, but my undergraduates' parents could buy and sell me on the market 8 times over, so they're much higher status than I am, which actually improves the monitoring by the supervisors, and I'm useless in the private sector. So generally speaking, even though many of us are paid by salary, there's usually lots of other things going on to make sure that we behave properly.
What is the role of peer review, right? Which is that in many cases where leslie said to people, forget about the journals, how your peers perceive you, for example, is something that does go into how you behave. That's right. In this setup, we have.
Cool. Well, actually, this is something I'm going to mention in a few minutes on hospital care. Who is a peer in a primary healthcare center. There are 2 doctors assigned to a primary healthcare center. One of them is frequently not even, one position is frequently not filled. So you're out there by yourself. It's unclear who a peer is. So in primary care, sending 1 or 2 doctors out to remote areas, there's very little peer.
So much in, say, Delhi, right, or a smaller city, where the network of people who work in these PHCs would know each other.
They know each other, but they don't necessarily see what they do every day. Let me get back to that because we'll talk about hospitals in just a second. Incentive problems, oh, yes.
I had a question before moving on. Do we know anything about how private MBBS doctors set the price of consultation fee? Because my confusion is, I see 2 effects happening, because yesterday we discussed that quality is perceived to be, it's correlated with price is correlated with quality. So if I am a private doctor setting up a fee, I would want to set it high so that people perceive that my price is high because I'm a good quality doctor. But at the same time, there are also, we have to take in account of the capability of people to pay. So there are 2 sort of.
Yes, actually, it's interesting you phrased it that way. You want to set a high price to signal your quality. It's also possible that people, if you set your price higher than your quality, people won't go to you either. So doctors are kind of, it's a complicated decision as to exactly where to set your price. And the data that I was showing said that in equilibrium, the higher, the better the quality, the more you can charge. So it is in fact a complicated story as to how the market equilibrates, something we don't know too much about. However, the basic data seems to see that the higher the quality, the more you're paid. Important part of the story. Quantity, quality, and price, all 3 interact. It's a complicated story, very rich area for research. Every medical system has to deal with this kind of incentive problem. No rich country in the world, however, pays their primary healthcare providers as per the previous slide, meaning salary, no monitoring, not being able to fire, et cetera, et cetera. In the UK these days, they started out with salaries, but now it's mostly capitation for primary care doctors, plus fees for specific services. And almost everywhere else, the government pays or ensures the payment for insurance, and almost all providers are private. So why exactly in the post-World War II era, all of these completely public systems were imposed on poorer countries when none of the rich countries had this is unclear to me. Interesting issue for historians, not for me. The principle in most countries is money should follow the patient, which is, remember I drew that triangle way up at the beginning and said that accountability was very important in general, and that one main form of accountability is whether or not the patient is satisfied. And one way of making sure that that kind of accountability is enforced is to actually give the patient the ability to pay. In fact, insurance is sort of a conditional voucher, which is if you get sick, you get to choose where you want to spend it. That's how most systems operate, where the doctor's payment is dependent on patients actually wanting to go to them. In the UK capitation, it's not each transaction, but each year people sign up for doctors, and the ones with the reputation for being conscientious or have given you good service in the past year more likely to be signed up again, and that directly relates to their income. Not necessarily every time they visit you, but the ability to satisfy the patient in general.
So they don't have the same problem where the patients are asking for antibiotics, because how do you define service?
How do I define what?
Define service. So when you say that I'm satisfied with the doctor or not, I would expect that the same problem occurs in other places as well.
Interesting. Your last 2 questions point to 2 issues that I like to summarize on why I don't really know how to do these things, but I know what things will look like when the world is better. One is that, we were talking about this the other day, I don't know how to do this, but sooner or later, patients are going to have to know not to ask for antibiotics. And in England, they don't ask for antibiotics when they're not necessary. And if the doctor tells them that it's not necessary, they kind of believe them. The other part, which is related to your previous question, is when things get better in India, it will be the case that there will be much firmer professional ethics. But we will get to that in a moment.
But you also see that more educated patients today. When you learn, somebody will say, oh, you should go to that doctor. He doesn't just prescribe antibiotics for everything. So it starts happening perhaps also as very poor, very literate versus...
Well, the diffusion of lots of things go from rich to poor, for good and for ill. Yes, we see that more among richer and better educated people, and I hope that it takes over sooner or later.
So in the malpractice in the UK, it would end the career, so they wouldn't ever risk distribution.
So there's more than just the patient. There's supervision, or if anyone supervisory got wind of that kind of behavior, they would be punished quite directly. This is not to say that there are no well-functioning systems that have salary. There are two very good exceptions. One is Finland and one is Sweden. What's interesting, actually both of these are informative, I don't know why I said just one. Finland and Sweden, I don't know much about it. I'm sure they have a very good health system. They have good for everything else, and I'm sure their health system is just fine. And they are all on salary. But in Finland and Sweden, the government unit to which they are from, the government unit that employs them are local governments. Now, I want to emphasize this for a second. Finland is a country of 4 million people. A country of 4 million people. That makes it a slightly larger than average district. And they don't think that their national government is capable of supervising doctors for 4 million people. This is Finland. Finland is Transparency International's #1 most honest place in the whole world. And they're very highly educated, and the central government does not think itself capable of monitoring their doctors. And here, if you were to talk to secretaries of health in states, I don't think they realize there's anything lower than a district. I've had my doubts sometimes in these conversations. And the district is bigger than Finland. And Finland is very law-abiding and very honest and yet they think they're not going to get good enough service by watching doctors unless it's by the local government. Sweden's the same way. Now, Sweden's a much bigger place. It's 10 million people. That makes it just slightly larger than the biggest district in India, which is what, West Midnapore or something, I think. But it's only a little bit bigger than the biggest district, Sweden. And in Stockholm, where there's 2 million people, that brings us back down to a district, they also thought that the local government wasn't quite doing well enough, and they've had a whole series of reforms. I think I'm quite bit behind the times, which introduced more competition between providers in Sweden. So I just wanted to point out that when issues of decentralization are discussed in India, it can be very surreal to people coming from outside who are dealing with used to dealing with much smaller units of government than we say is competent to handle government procedures in India. So the core question is, how do you pay doctors? How do rich countries do it? This is really dated, but the point's made. His point's easily made. I don't know if you can see this so well, but we have over on, these are different ways that you could pay your doctors. On the left, there's fee for service. On the right, there's salaries. And in the middle, there's a mixture of stuff. And in fact, you can see that those countries that pay doctors fee for service do in fact have more things done. Now the y-axis here is number of healthcare visits in a year.
Explain fee for service, who's paying?
It's somebody is paying for every single thing that a doctor does.
So it's not you who wants to do it.
No, they get, sorry, look at, it's government pays all of this stuff. This is just how they get paid. And the way that the government gets billed by the doctors is I gave them this shot, I did this procedure, I did this kind of thing, and they get paid more for each of the things that they do by the government. None of these countries have private.
Is there an existence of private market where, let's say, I go to Dr. A and that's paid by the government, whereas Dr. B is not, or within A procedure is paid by the government, but is there a variation or is it?
Yeah, there are some variations. Some of these, for most basic services, most of the insurance is either provided by government or it's very heavily regulated by government. But in most of these countries, there is sort of you can top up, you can pay more for other things. But most of this is within the system of payments by government. So the fee for service, the y-axis is number of visits per year. This would ordinarily include somebody's checkup, but once you see a doctor in most of the rich countries, then subsequent visits you either really do get sick, fine, but also the doctor schedules you for follow-up visits. So quite a number of the number of healthcare visits is quite a bit. There's a lot of doctor input into this. It's just not just whether you get sick. And you notice that all of the ones that pay fee for service have more healthcare visits per year. And the two, plus Portugal, I'm not sure that's really much of a model, but Finland and Portugal, which we just said are all salary, they don't seem to tell people to come back very often, and possibly because they don't particularly want to see they don't want to do more work than they have to either, which might have been some of the problems in Sweden in the first place. And then there's mixtures. There's fees and capitation. There's a mixture, again, fees. In the UK, most of the payment is done by capitation for primary healthcare. But then there are fees for particular important services like immunizations and whatnot, which is a way of encouraging them to do immunizations. All payment systems have to strike a balance between too much care and too little care. Fee-for-service should be creating incentives to do too much, because the more the doctor does, the more he or she gets paid. This actually is something even I can understand. However, we notice that in India, it might be a little bit more complicated because we don't actually see that in primary care very much. Something of a mystery. Being salaried always creates incentives to do too little, and that we've seen in many dimensions in India. And in between, there's many options. They all have pros and cons. Capitation, usually too little, because there's no particular reason to do anything extra for a patient except to sort of keep them generally happy. And diagnostic related groups, you get paid a certain amount depending on the illness that you see. But once you get paid, there's no incentive to do more than the minimum on that. So that frequently ends up too little also, but that depends. But now we're talking about stuff that's just as relevant to hospital care as to primary care. So we're going to go into our last topic, where hospital care does have these same issues. The impact on hospitals on health It's not so clear in aggregate. Now, obviously, person by person, it's very important to have a hospital. You get a broken leg, you need a hospital, you get fixed, and that's a big impact on health. However, it isn't frequently the case that most people, most years, actually need a hospital. So sometimes in aggregate statistics, hospitals may or may not show up as particularly important. I don't know. However, on financial security, the protection against catastrophic loss, that is, money that you'd have to pay to a hospital if you were going to cover its cost, is very important to people. And even if you don't need it every day, the very fact that you might is sometimes a large source of stress and anxiety and disutility. So that's something we really have to worry about for hospitals. The incentive effect of the payment systems involves the same set of issues as primary health care, but more so because we're talking about much larger sums of money. And in fact, for India right now, in thinking of how our insurance systems designed, the treatment decision to treat in a hospital rather than primary care is actually one of the main issues that RSBY has had to deal with, and that every insurance system has to deal with. One of the design features of RSBY is that it mostly covered hospital care, but obviously that gives an incentive to have people moved into hospitals, whether or not that's the appropriate thing to do. Hospitals are in fact very expensive. In any case, somehow or other, we have to deal with paying for hospital care. It could be, and in most rich countries, it ends up being insurance, but insurance has its own administrative problems that are quite difficult. The estimates are Canadian doctors and hospitals overbill the Canadian government by about 10%. That's acceptable to the Canadian people. They're very proud of their health system. They say 10%, say, fine, whatever. However, you might wonder, how much would a private Indian doctor overbill the government if given the authority to do so? I'm not sure it would be in the 10% area. I'm not sure. So the same thing, I want to look at efficiency effects. I'm going to maintain there's a very high efficiency effect of dealing with the catastrophic care that needs to be done in hospitals. There's a high potential, but a very low actual equity improvement by by hospital cares as they are currently implemented in many places. And again, I'm going to wave my hands about the implementation problems because there's so little research on exactly how easy or hard it is to implement. I am going to suggest that it might be easier, at least than primary care. On the efficiency effects, insurance markets always fail. We discussed this in the first session, adverse selection, moral hazard, blah, blah, blah. It's very possible that there's no insurance market at all or only for a very, very thin veneer at the top of the income distribution. Every country has to deal with it. Insurance markets always fail. Avoiding catastrophic financial loss is a problem that everyone faces. This isn't just for poor people. An appendectomy, which requires a clean operating theater, a doctor who actually knows what they're doing, a surgeon who actually knows what they're doing, an anesthesiologist, or this or that. It's going to cost $400 American no matter where you are in the world. $400 American out of pocket is impossible for the vast majority of the Indian population. Sometimes in Delhi, we sometimes forget exactly who the Indian population is, but $400 is really unaffordable for almost everybody. And there's and when we look at surveys, there's a great fear of falling into debt and inescapable poverty from the poor and the nearly poor. And that has to be because of the large hospital bill. Nothing that can be done at a primary health care center can actually push you that far into poverty. Antibiotics cost, what's the MRSP of a packet of antibiotics? It's 50 rupees, 60 rupees, something like that. And a very short consultation. That's not going to push you into inescapable poverty. A hospital bill could do so. $400 could certainly do so. Now this one, since time is running short, I don't really want to go into this in great detail, but I sort of need to say something about this in order to explain my next slide. We're trying to come up with a quantitative estimate of how much is this protection against risk, this protection against catastrophic financial loss actually worth in money terms. And this is a standard kind of way of trying to estimate the value of a risk premium. In this diagram, exactly how much jargon should I use? I'll try to keep it to a minimum. The conception of risk aversion all depends on the curvature of a utility function, which is the blue curve that I have drawn there. The more bent it is, the more scared you are of losses. We usually think utility functions look like that anyway because there's diminishing marginal utility of income. And using that, we can look to see how much might you be willing to pay for insurance to protect yourself from a terrible outcome. So Y sub H is how much you would make if you don't get sick. So that's pretty high. If there's no insurance and you're going to face a cost of medical treatment, capital C, your income or your available income after this expenditure is Y minus C, which is way over to the left, which has pushed you way down on the utility function. If the probability of this terrible thing happening is rho, which is the small p-looking thing, then your expected income would be your healthy income minus the cost that you would have to pay if you got sick times the probability of getting sick. So that's Y minus YH minus rho C is your expected income after health expenditures. But because there's a chance, rho, of being pushed way over to the left, you might be willing to pay something to prevent that eventuality from happening. And so this diagram sort of looks, how much would you be willing to pay to avoid this risk? And it turns out it's the amount that would give you the same utility, expected utility, as that Y health H minus rho C. 1 second. And it turns out that we might be able to measure this loss of welfare by not having an insurance system to protect you as the quantity pi, which is $1 equivalent for how much your utility is lost by having to face this risk. If you didn't follow that, it's okay. All you need to know is pi is a dollar figure for characterizing the value of protecting you from risk. I just wanted to show you that I didn't make it up, and it comes from something in particular. It's related to your income relative to costs, so it's related to Y and C. It's related to the probability of illness. It's related to the curvature of the utility function, but in fact, they can be estimated if we look at some possible parameters. Yeah, was there a question?
What's the difference between YH and Y?
Y is just the label of the x-axis, and there should be a YH on the Y over to the left. Y minus C should be YH minus C. Okay, so I'm contending that we can put a dollar value on this, the value of not having an insurance market, how bad a welfare cost it is to not have insurance or not have the promise to treat you in a hospital. So now looking at data, for very old data, because I don't even want to go into why this data is so old, we have estimates of how often do people get sick and have to use inpatient facilities, that's hospital. How often do people get sick such that they have to use outpatient facilities, that's outpatient facilities. How much does a typical outpatient visit cost in the private sector? How much does a typical inpatient episode cost in a private sector? And for the curvature, we used a standard estimate that was done on ICRISAT data in South India on how much farmers would be willing to pay in bets. It was an estimate for an estimate of risk aversion that Hans Binswanger did 30 years ago. And so that was sort of the closest we could come to what this curvature is. If you put it all together and then graph it against the income of poor people versus rich people, you see a couple things here, kind of interesting. First of all, for everybody, this welfare loss is fairly substantial, even for rich people. So this is the value of insurance, that was the pie, that quantitative estimate of the value of insurance, relative to the cost of this problem, which is rho minus C, expected cost. Even for rich people, the value of insuring them against this eventuality is close to 20% of the cost of the service itself. That's really high relative to other rates of return on investment in public investments. Of course, richest quintile in India puts you way down to extremely modest levels of very modest levels of income. So it's not too surprising that this would be so valuable. But because the average cost of an inpatient visit in India is so much larger, a fraction of income for poor people than for rich, this protection from risk is incredibly valuable for very poor people. We're talking 50% rate of return over the actual expected cost of providing the service. This is a spectacular increase in welfare if people could be protected from catastrophic loss. When we look at outpatient, as I said, outpatient visits, 50 rupees for the consultation and another 50 rupees for the antibiotics. It's not nice to have to pay that, but actually the risk part of this is quite small. Even for poor people, it's well less than 10%. So there's two things going on. Poor people should be much more appreciative of being protected against loss, and that loss is much greater for inpatient problems than for outpatient problems. However, that was my argument for, on efficiency grounds, it's very important to either deal with insurance, and if insurance is too hard, to provide free hospital care. Incredibly strong efficiency argument for helping out on hospitals. However, a big dilemma is the way that hospital subsidies are paid in the world. We have a terrible equity problem. We have an efficiency problem going, absolutely one of the most important things we can do, but it's going to way disproportionately go to rich people. So efficiency going one way, equity going the other, big dilemma. This is healthcare subsidies in Indonesia. It's similar in lots of places, and you can see that hospital inpatient, hospital outpatient for that matter, those are the black lines, are captured way more by wealthier people than poor people. Yes, these are public facilities. They're all public facilities. And it's not too surprising. In fact, it would be surprising if it didn't turn out this way, at least for outpatients, inpatient, I don't know. Because where do you put a hospital? You put a hospital where there's population density. It's sort of stupid to put it in the middle of nowhere, where the density of people have to travel long distances to get to it. Of course you put it in a city. Who lives in cities? Well, in most countries, it's relatively well-off people, and the people who take advantage of these facilities are going to be the ones nearby, and they happen to be well-off. I don't really know how you fix this. However, one of the things we might think about for what would help poor people in India. India's picture is not very different from this. And that would be, how do we get poor people to hospital when they actually need a hospital? That would be a really great problem to solve. We know that it's very important to them to not be pushed into deep penury. It's not easy because it hardly ever happens on its own that the equity, that poor people get to use hospitals. They don't get to use hospitals in Delhi. Even poor people in Delhi don't use public hospitals very much.
But the rich have moved to private hospitals in Delhi, just anecdotally, obviously, we don't have data.
Actually, rich people use more medical care across the board. They use more private medical care. They use more public medical care too.
Let's visit Safdarjung, just as an exercise. And the waiting time is about 6 hours or so. And very few rich people are willing to go wait without even a ceiling fan for 6 hours. So what you call rich might be rich compared to the person living in a rural area. But if you just look at the distribution of income of the population in the region that it can cater to physically, maybe it's different.
I think rich was a bad word, because in this case, we're looking at income groups by decile. The break point for the top decile, the 90th percentile, is the last I heard that some estimate of the middle class was really the top 8%. So that's 10%.
Physical distances as well.
It does. And relatively well-off people, relatively well-off as opposed to rich, live in cities, and they will use that facility more. But not rich. This is
the auto driver or the gardener here. Those are the rich in this.
Yes, that's right. That's right. We're talking deciles. We're not talking the 1% of the 10%. We're talking large categories of people. So the top 10% is actually, the break point is quite modest. But again, equity going one way, meaning bad, efficiency going the other, meaning good. And now let's go to that last dimension of how easy is it to implement. Well, actually the insurance part of this, this is very, very old data. This is when RSBY was first introduced. Things I hope have gotten much better than this. This is the first 103 districts that were using RSBY in the country. And what this diagram shows is how often do the RSBY boards run out of money. That's the burnout rate is, if it's over 100%, they've run out of money by the end of the year. And here, this was also showing that the more that you induce people to use hospitals, the more likely you're going to run out of money, or the more money you're going to use. That seems obvious. But you notice that 100%, there's a third of the districts in the first year ran out of money. And so this is one of the reasons why I think insurance may not be the thing that's going to really solve it unless they get a real handle on how to manage insurance systems. This is in the very early days, it seemed like it was hard to do. Perhaps things have gotten much better. I haven't been paying that much attention. However, insurance systems, I think, are fairly hard to run. Let's look at hospitals. Running a hospital, I would contend, is easier than running a network of primary healthcare centers. I've mentioned this to lots of people and they attack me on this. And so I'm perfectly happy to back off. This is speculation on my part as opposed to firm data, which I do not have. The incentives problems are the same. On the other hand, the doctors are all in front of you. There's a bunch of doctors in the facility as opposed to you don't know where they are. And so that would be an a priori reason to suspect hospitals could be run more easily. Coming back to your point, it's only in hospitals that you would get peer supervision. It's the only place where there's a bunch of doctors who you need to show that you're doing a good job, who know that what you're doing each day. It's really only in a group of doctors where anything like that is likely to happen. Another a priori reason why I think hospitals might be easier to run than PHCs.
Why do you say you have no evidence? In the graph that you showed for poor, middle, and rich, in the top, on the top for the poor, where your left, your outlier was PHCs, public doctors in PHCs. On the right, for the hospitals, it was far to the right. So why do you say you don't have evidence?
Oh, thank you very much. Yes, I have evidence that. Actually, the hospitals in Delhi, the three that we looked at, they did pretty well, all things considered.
Where even for the poor,
Even for the poor.
That it wasn't just for the rich, but even for the poor, there was poor.
Yeah, well, the hospitals are the same hospitals. It turned out that poor people wouldn't go to those hospitals, but the hospitals ran themselves fairly well. However, I'm also attacked by friends who say, yeah, well, you looked at Safdarjung, Hindu Rao, and GB Pant. That's not exactly the same as Sitapur District Hospital in UP. And I'm told it's not nearly as good. So I don't want to say that this is something simple. I'm just saying I think there's a chance we could run our hospital system in ways that it might be a little bit too hard for us for the primary healthcare center. Another reason, a priori, it's a little bit of empirical evidence, but not really on target, is staff satisfaction is likely to be higher in hospitals than in smaller facilities. There was a study in Andhra Pradesh that asked doctors, what is it that led to satisfaction with work? And the things that they mentioned were being able to use the knowledge that I picked up in medical school, being able to have equipment that allows me to use the knowledge that I picked up in medical school, and having colleagues to discuss interesting cases with. Where on earth does that happen? It happens in hospitals. It does not happen in primary healthcare centers. So there's more of a chance that that doctors could be kept or would show up for work, would be happy to do so, would have enough job satisfaction that you're not fighting against them every day, and that I would suspect that that's an easier set of employees to manage than a dispersed network.
Are there not unfilled vacancies in hospitals as well?
I don't know. I have never looked at that. Anecdotally, less than primary healthcare, but I honestly don't know. Good thing to look at. In fact, let me see what the next slide is. Yeah. It's a very good thing to look at. We should find out stuff like that, but whether there's a lot of vacancies. That's not hard to do. Hospital functioning and quality is a vastly understudied area. We know almost nothing about this as far as I can tell. We need some, all of those things about measuring quality of primary healthcare doctors only for the simplest cases and only for outpatient departments and only for primary healthcare type of problems. As far as I know, there's nothing that directly measures the quality of clinical advice and care for hospitals in India, and there's very few things like that, even in the United States, which is quite measurement intensive because insurance companies like to know some of this stuff. Big academic initiatives on trying to measure care in medical care in the U.S., and I'm not aware of any particularly good measures of clinical quality. Doctors don't actually like to be second guessed on this, which is one of the reasons it's hard to do. But I think that I am willing to propose that hospitals are easier to run than primary healthcare centers. I don't know. I don't have the data. I really wish we could find out more about that. So my summary is lots of things I don't know. I do know that hospital care is very important for protecting against financial catastrophic loss. Efficiency effects are potentially very high. The equity effects are potentially high because we showed that poor people are way more vulnerable to big expenditure demands than rich people. So the potential's there, but the way that it's actually happened in practice is not good at all. And the distributional impact of hospital subsidies has not been good to date. And again, I wave my hands about the management. I suspect that hospitals are easier than primary health care, and that was the summary for that third section. So to summarize the entire presentation, we can ask the question, can policy improve health? The answer is, of course it can. And if done right, it can improve welfare too, including the financial protection, which subsumes health, and is a very high priority for government expenditures. But don't let them fool you. The first priority for India is still the traditional public health, the sewer systems we don't have, the swamps that have not yet been drained for that breed mosquitoes, the clean water, the sanitation, the information about nutrition that we should be giving mothers, et cetera, et cetera. All of the traditional kinds of things are not done anywhere near well enough. Fine. For middle income countries, and so India soon, we hope, although it's already classified as a middle income country, isn't it?
Getting
Yeah,
there,
just there.
getting there.
It's a lower middle.
Yeah, it seems like there's two countries, and the country that I'm familiar with is not anywhere near middle income. But in any case, as India gets richer, which it is doing continuously, we will need to deal with insurance either directly, that is, if we can get insurance systems to work well, monitoring them properly, or with heavy subsidies to public hospitals. RSBY needs a closer look, but for the time being, I think we probably need to get the hospital system working better. There was the gentleman yesterday from UP who was quite adamant, I think, in saying that the public hospitals have to be brought up to speed in order to compete for RSBY funding. So quality of medical care in public hospitals, something we really do have to look at. And then, this is the part where I'm always in the minority, primary health care, that middle section, where everything was really ambiguous, was probably never the right way to go, even though that's what the international community has said and what universal health care is all about. I'm not sure about this, and perhaps you'd like to discuss that among yourselves. Thank you.